Hello everyone. So today we will start our next topic, that is autonomic regulation of heart. So far we had discussed all about the abnormalities we have seen in ECG. Today we will discuss about the autonomic pathway, what are the cardiac and the vascular receptors and how signal transduction occurs in these receptors, that is the cardiac and the vascular signal transduction. Now before moving on to the main topic, we will discuss about this ECG. This is the patient who has presented in an emergency with a severe chest pain for half an hour. So, what we see in this ECG, the first and foremost we should see about the sinus rate. So, the rate is, if we just calculate, so we have 1, 2, 3, 15 and 17. So, 1500 by 17, it will be approximately 80 beats per minute. It will range between 75 to 80 beats per minute, that is the rate. So, and then the rhythm is usually what we are saying over here is regular. So, it is a regular rhythm. How we are getting the PQRS complexes? So, P wave is usually normal. We are having a P wave, which is the P waves are usually normal. Then the QRS complexes also we are getting within the normal range. Now, if we see for the, we have to see for the T waves. For the T waves, we can see T waves and ST changes. We can see in the lead 1, there is ST segment elevation. So, in lead 1 we have seen ST segment elevations, we have to find out where we have other ST segment elevations. We do not have in lead 2 and lead 3 AVR, we have in AVL ST segment elevations. T wave inversion is not yet, we can see T wave inversion also in case of AVL, as well as very less T wave inversions we can see in lead 1, but in case of AVL we can see T wave inversion. So, lead 1 ST elevations AVL, lead 1, and also we can see it in V2, V3, okay, V2, V3, V4, V5, V6. So, ST segment elevations we are getting from V2 to V6, which means the anterior leads as well as the lateral leads, with the lateral leads is 1 AVL and V5, V6, usually the lateral leads depicts that, and anterior we have generally V2, V3, that is V3 and V4, but here V2 is also affected. So, anterior and lateral portions we could see, and we have seen the T wave inversion in case of AVL leads, and we did not see any of other T wave inversions. Also some we have seen in case of V4 leads T wave inversions, and also we could see few Q waves. We could see few Q waves in case of lead V2 and V3, we could see Q waves. In case of lead V2, V3. So, we do not have any other Q waves which I am not able to see right now. So, ST segment elevations in case of lead 1 AVL V2 to V6 with T wave inversion I have seen in AVL, T wave inversion is present. Q waves is seen in V2 and V3. So, which means this is acute, ST segment elevation is there. So, definitely it is acute anterior leads as well as lateral leads. So, it is acute anterolateral STEMI or acute anterolateral ST elevated myocardial infarction. So, this is the diagnosis of this patient presenting with such symptoms, with severe chest pain as well as this ECG. So, with this next we will move on to the autonomic nervous systems. Now, with the references or with the lectures so far we have covered in abnormal ECGs, it is not very easy to become a pro in ECG unless and until you practice seeing the ECGs regularly. So, if you just go through various ECGs regularly and with the concepts, then you could easily make out what are the changes in the ECG very fast. So, nervous system, we have central nervous system, peripheral nervous system. Central nervous system consists of brain and spinal cord, and peripheral nervous system we have autonomic nervous system, somatic nervous system. Somatic nervous system, through somatic nerves supply the skeletal muscles, and autonomic nervous system through autonomic nerves, that is sympathetic nerves and parasympathetic nerves, they usually supply the various target organs like glands, cardiac muscles, and we have various blood vessels. So, these are the target organs. Now, what is the autonomic pathway? Generally the autonomic pathway consists of two neurons, and these neurons usually make a synapse in the autonomic ganglion. Now, the postganglionic neurons, the activity of the postganglionic neurons is actually regulated by the preganglionic neurons, whose cell bodies are present in the central nervous system. So, this is the preganglionic neuron, the cell bodies are present in the central nervous system. This is making a synapse, that is autonomic ganglion, and from here the dendrites which we are getting, that is postganglionic neuron, and this postganglionic neuron is making the synapse with the target tissues, whichever target tissues like glands, cardiac muscles and the blood vessels. Now, this autonomic pathway, the morphology is different in case of sympathetic nerve fibers and the parasympathetic nerve fibers. In case of sympathetic nerve fibers, the preganglionic neurons are usually shorter. Now, before that I would like to say that all preganglionic neurons are cholinergic. You have to remember this, that all preganglionic neurons are cholinergic, that means they secrete the acetylcholine, and postganglionic neurons, depending on the nerve, whether it is sympathetic or parasympathetic, the neurotransmitter will be secreted. So, in case of sympathetic nerve fibers, the cholinergic neuron, the preganglionic cholinergic neuron, you can see this is very short, and the postganglionic nerve fibers, this is very long. So, sympathetic fibers have short preganglionic neuron and long postganglionic neuron. The reverse is occurring in case of parasympathetic fibers. We can see there is a long preganglionic neuron and there is a short postganglionic neuron. Now, the cholinergic nicotinic receptors, the receptors for the acetylcholine, that is nicotinic receptors and the muscarinic receptors. So, the nicotinic receptors are present in the autonomic ganglion. Here generally we get the N2 nicotinic receptors, N1 receptors are present in the skeletal muscles. So, N2 nicotinic receptors are present, and the cholinergic muscarinic receptors, obviously in case of parasympathetic pathway, the postganglionic neurons will secrete acetylcholine. So, when it will secrete acetylcholine, this usually bind to the muscarinic receptors present in the target tissue. If the fiber is sympathetic, it will secrete norepinephrine, and this will bind the adrenergic receptors present in the target tissues, that can be alpha and beta. Also epinephrine, which is secreted from adrenal medulla, they also bind to this adrenergic receptors, that is alpha and beta. So, what we are seeing in autonomic innervation of the heart and vasculature, the parasympathetic or the vagal fibers, this is the long preganglionic fibers which are coming from the central nervous systems, and in the heart itself it is synapsing, and the postganglionic fibers are very short, whereas the sympathetic fibers are travelling all along the spinal cord, and the sympathetic ganglion, they are synaptic and the sympathetic ganglion, this have the preganglionic fibers which are short and the postganglionic fibers are long, and these are terminating both in the heart as well as in the blood vessels. So, the receptors what we see usually, the vagal fibers, they are terminating in the SA node and the AV node. They modulate usually the sinoatrial node and the atrioventricular node, and usually the sympathetic fibers, they innervate the myocardial fibers as well as the blood vessels. So, the heart, usually the receptors, adrenergic receptors, we get beta 1, adrenergic receptors we get beta 1 and beta 2. M2 muscarinic receptors is usually present in the heart. Adrenergic receptors which we get in the blood vessels, that is alpha 1 and alpha 2, and M3 receptors usually we get in the blood vessels. So, what are the functions of this receptors? Generally the adrenergic receptors alpha 1, beta 2, alpha 2 is very generally it is located vastly in the central nervous system and the brain, and in some junctional blood vessels, but alpha 1 and beta 2, that is very important over here. So, alpha 1 the agonist is norepinephrine, beta 1 and beta 2 is epinephrine. So, alpha 1 causes vasoconstriction, there will be constriction of the blood vessels, arteriolar constrictions as well as venoconstrictions. The epinephrine binds to the beta 1 receptors, that will cause increase in the heart contractility, increase in the heart contractility, increase in the heart rate. We will come to the mechanisms later. Beta 2 receptors, epinephrine also binds to the beta 2 receptors and cause vasodilatations or bronchodilatations. So, the actions of beta 2 is just opposite to that of the beta 1. The beta 1 epinephrine causes increase in the heart rate, increase in the contractility, but beta 2 epinephrine causes vasodilatation, bronchodilatations in the lungs. The muscarinic receptors or the cholinergic receptors, they bind to the acetylcholine and they causes the vasodilatation and decreased heart rate and decreased contractility, force of contraction, as well as vasodilatation. So, what are the general or overall effects on the heart? So, chronotropy is the increase in the rate, ionotropy is the contractility, ionotropy coming from the ions, calcium ions, lucitropy means relaxation rate, dromotropy means conduction velocity. All this will get increased in the under the sympathetic stimulation, and the parasympathetic stimulation we usually will decrease all this. Specifically the ionotropy and lucitropy effect is related to the atrial musculature or atrium, and in case of blood vessels usually parasympathetic does not have any innervations, except the major dilatory effects are seen in specific organs like penis genitalia. Besides that, the blood vessels, arterial the vasoconstrictions, which includes arterial constructions and the venous constructions, the sympathetic innervations usually play a very important role in that with the vasoconstrictions. Now, what is the cardiac signal transduction mechanism? The cardiac signal transduction mechanisms is usually linked with G protein. Now, G protein is G stimulatory protein and G inhibitory protein. So, whatever actions G stimulatory protein will have, the opposite role G inhibitory protein will occur. So, G proteins are usually attached to a molecule that is adenyl cyclase. So, adenyl cyclase usually what happens whenever norepinephrine or epinephrine is binding to the receptors present in the related to the G stimulatory proteins, for example, beta 1 and beta 2. So, beta 1 and beta 2 receptors. So, this norepinephrine and epinephrine will bind to the G stimulatory proteins and stimulate the adenyl cyclase enzyme. Now, this beta 2 I am talking about the heart, which will which will increase the contractility. This is the cardiac receptors I am talking about. So, adenyl cyclase will get stimulated, there will be formation of cyclic AMP. So, increased cyclic AMP because of this adenyl cyclase enzyme stimulation will cause increased formation of protein kinase. This protein kinase will cause increased calcium influx. This increased calcium influx will cause more contraction. This is exactly reversal occurs in case of G inhibitory protein, and the receptors are one, we already know the muscarinic receptors acetylcholine, the muscarinic receptors, also we have adenosine which binds to the A1 receptors. They bind to the G inhibitory proteins and the adenyl cyclase enzyme will be inhibited. So, the cyclic AMP will be inhibited, there will be less protein kinase and there will be less calcium influx, and thus relaxation or the less contraction of the muscle. So, that is how the cardiac signal transduction occurs. This I am repeatedly telling because beta 1 and beta 2 I have already told it is very important in case of vasodilatations. Now, that is beta 2 for the vessels, blood vessels. Here I have said the beta 2 increasing the contractility in case of heart rate, in case of cardiac receptors. So, beta 1 and beta 2 G stimulatory protein and acetylcholine or muscarinic, that is G inhibitory protein. Now, coming to the vascular signal transduction mechanisms. In case of vascular signal transduction mechanisms, beta 2 receptors which bind to the G stimulatory proteins, what it will cause? Again the same, it will stimulate the adenyl cyclase enzyme. Now, this vascular signal transduction means it is occurring in the blood vessels, and blood vessels are nothing but the smooth muscles. But here the mechanism of contraction of the smooth muscles is bit different compared to the other muscles. Now, because of the adenyl cyclase enzyme activation, there will be increased formation of cyclic AMP. Now, this cyclic AMP is actually a inhibitor of myosin light chain kinase. What is this myosin light chain kinase? Now, in case of smooth muscle contraction to occur, whenever calcium binds with calmodulin, the calcium calmodulin complex and the myosin light chain kinase activated, this will cause the contraction of the smooth muscles, here in case of vascular smooth muscles. But this happens, this myosin light chain kinase, this gets activated in presence of ATP. Now, whenever we are utilizing the ATP in the formation of cyclic AMP, that means the ATP is decreased, which means actually the cyclic AMP is an inhibitor of myosin light chain kinase. So, there will be no calcium influx and there will be no contraction of the muscles. So, that means the beta 2 is actually causing through G stimulatory protein relaxation. In case of vascular smooth muscles, it will be vasodilatations. Now, similarly, the opposite occurs in case of alpha 2 receptors, where alpha 2 receptors bind to the G inhibitory protein. Now, when alpha 2 receptors are binding to the G inhibitory protein, which means ATP will be more, adenyl cyclase is inhibited. So, ATP will be more and cyclic AMP will be less, which means the myosin light chain kinase will be activated and there will be contraction. So, vasoconstrictions occurs because of the alpha 2 receptors, but usually the action of the alpha 2 receptors is balanced or counterbalanced rather with the beta 2 vasodilatations in our body. The next is the alpha 1 adrenoreceptors. The GQ proteins present in the vascular smooth muscles are coupled with alpha 1 adrenoreceptors, and the specialty of the GQ proteins is they act through the second messengers inositol phosphate and diacyl glycerol. So, IP3 and diacyl glycerol, again this will cause increase in the protein kinases and this will cause calcium influx, and this calcium influx will cause contraction, hence contraction of the vessels occurs because of the alpha 1 adrenoreceptors, but alpha 1 adrenoreceptors specifically bind to GQ proteins which is acting not via adenyl cyclase, but IP3 and DAG mechanisms. Now, in case of vascular smooth muscles, we have M3 receptors. M2 receptors we have seen in case of cardiac muscles and the action is just binding to the G inhibitory protein. But in case of M3 receptors in the vascular smooth muscles, they act via binding to the act via releasing the nitric oxide. So, nitric oxide, it is the vascular endothelial relaxing factor which causes relaxation or the vasodilatations of the vascular blood vessels. So, this is the mechanism of G protein coupled signal transduction. So, here we have seen what are the autonomic pathway, the sympathetic pathways and the parasympathetic pathways, the various receptors present in the heart along with the innervation, the cardiac receptors and the vascular receptors, beta 1, beta 2 receptors in the heart and alpha 1, alpha 2 receptors in the blood vessels, M2 receptors in the heart, M3 receptors in the blood vessels. So, and we have seen how the signal transduction occurs through various cardiac receptors and vascular receptors. This much you have to know in the cardiac autonomic regulation. Thank you.